Hi, I'm Dr. Nadim Khan, practicing as a consultant diabetologist in JD Hospital, Kolkata. Today, I'm going to explain about the case study of 57 years old man having a history of type 2 diabetes, hypertension, and macronuria. He came to me because of some acute problem as a ACS 1 year ago, and he's on metformin 1 gram, glimepiride 4 milligram OD. He's on losartan, atorvastatin 40 milligram, amlodipine, clothianidine, metoprolol, aspirin 75. Still, with all these, a combination, his HbA1c is very high at zero point 0.2, effective GFR is 88. His cholesterol is more or less normal. His creatinine is normal, and effective GFR is 65. So we can say that he is in stage 3 to 4, and his UACR is 150. That is his macroalbuminuric. And physical examination is obese, blood pressure is normal. So noise control is very important for cardiovascular protection, and this should be the primary treatment for all, physician and diabetologist. The primary A1C goal for any non-pregnant adult of less than 7% is appropriate. On the basis of this achievement, the HbA1c should be as low as possible, that is around less than 6.5. So a better management during the last two decades allowed reduction in the incidence of cardiovascular complication, yet the residual risk remain high in the patient with type 2. CKD remain a great concern. So renal disorder is common in type 2 diabetes, where approximately 50% patient develops some degree of renal impairment. The risk of renal disorder in type 2 includes the development of multiple phenotype organ damage. The EMPA-RACE trial, one of the best trial, was randomized, double-blind, placebo-controlled phase 3, which involves around 7,020 patients with type 2 diabetes, with all were having the established cardiovascular disease. Their effective GFR at the baseline was 74.1, and UACR was 18 milligram per gram. So the prescribed renal outcome in this study includes the worsening nephropathy, which is defined as a progression to the macronuria, doubling of the serum creatinine associated with effective GFR. So this is compared with the placebo. Empagliflozin was associated with significant improvement in the post-hoc composite endpoint of incident and worsening nephropathy with cardiovascular death. The inhibition of the SGLT2 leads to tuberculosis with feedback via enhanced natriuresis and delivery of the sodium to the macula. So this is the mechanism by which it is working. Now the DP1 inhibitors reportedly ameliorated renal function and pathology in DKD. So linagliptin decreased podocyte adipocytes. So this is another advantage of this linagliptin. The Caminera study, which is for the linagliptin, has shown cardiovascular outcome study that linagliptin reduces the progression of the urea by 14%, reduce risk for progression of urea. Moreover, linagliptin demonstrated cardiovascular safety also. So lina slowed progression of urea without affecting effective GSR, slope, or other kidney outcome. So a strong relation of combining D4 inhibitor and cardiovascular protection. Class SGL2 in the patient with type 2 becomes two drugs exert different complementary glucose lowering effect. So this combination is really doing good, and which we have seen in real life to our patients, which is providing HbA1c reduction to the tune of 1.1 to 1.5, and weight reduction to approximately 2 kg when added to metformin, which is the primary place of therapy. So the phase 3 randomized trial investigating efficacy and safety of the IMPA and LINA beta tolerability was observed. So this is the one of the advantage that adding, the linagliptin with the IMPA just reduces to some extent the genital infection. The fact implies that IMPA and LINA add-on metformin should equal or even better tolerability than monotherapy. So this unique combination is really very, very useful for our patient to intensify the blood sugar control, and because of the good glycemic control, tolerability, and weight loss. Thank you very much for patience hearing.